Hello everyone and a warm welcome to our Bump2Baby and Me forum. I'm Jo Balding from Beta Technology in the UK and we are a partner in the Bump2Baby and Me project, and I'll be your host for today's event. Bump2Baby and Me is a 5-year project funded by the European research programme Horizon 2020 and Australia's National Health and Medical Research Council. Delivered by an international consortium of partners, the focus of the project is to undertake a randomised controlled trial to test a novel healthcare intervention during pregnancy and for the first year after birth. The ultimate aim is to provide policymakers, healthcare decision makers and health service commissioners with a cost-effective, evidence-based healthcare intervention to help prevent maternal and child diabetes. Throughout the project, these forum meetings will bring together policy and health stakeholders around a related topic or challenge. And the topic for today's discussion is pregnancy and early life, an opportunity to address obesity. We hope to not only raise awareness of the Bump2Baby Me project, but also to gain stakeholder input, get to know one another and exchange our knowledge. It's great to see a range of international stakeholders have joined today's meeting, with representatives from academia, intermediary organisations, local governments and regional health representatives. Thank you for joining us. Before we get started, I'd just like to run through a little bit of housekeeping with you. For our future reference, this webinar is being recorded and transcribed. The recording will be publicly available after the event. Please could all participants please remain muted unless you're invited to speak, but please do leave your cameras on if possible, especially if you are speaking. You'll be able to ask our speakers questions after all the presentations have finished. We'll then open up for the floor for further questions and a more general discussion. If you'd like to ask a question, please use the chat function or use the raise a hand emoji at the top of the screen. Please like any questions in the chat that you wish to see answered, and then if we're running out of time, we can prioritise those that are most popular. And by all means, please do use the chat function for any observation or comments. The aim is this is an informal networking event, which of course is really difficult when the event's virtual. But please do use the session to raise any questions, share your experience and knowledge, and please do introduce yourself to your fellow delegates. So obesity is one of our greatest long-term health challenges, and today I'm very pleased to welcome 4 presenters from both the Bump2Baby and Me project and another organisation, each bringing a different insight and knowledge to obesity in pregnancy and early life. We do, however, have one presenter that's not able to join us today, so we have a colleague stepping in as well. But first of all, I'd like to introduce you to Jacqueline Bowman-Bussato from the European Association for the Study of Obesity. So over to you, Jacqueline. Thank you.
Thank you so much. It's my absolute pleasure to be here this morning. And I see from the list that also one of our real experts, Jennifer Lynn Baker, is also on the call. So Jennifer, please speak up as we go through. I'm going to give a very short overview. I was asked to talk about the roots of obesity. Sorry. From a policy perspective. And I think that's one which is really important because within the policy world, to put it bluntly, evidence and facts don't often translate into policies that are supportive. So let's start off with a definition of obesity. Now, when we're thinking about women and or men in the fertility game, people with obesity already, what are we thinking about? Now, from a policy perspective, unfortunately, there's still quite a few myths and inaccuracies floating around. When we think about obesity and how to tackle obesity in the policy environment, weight gets brought up a lot, BMI gets brought up, energy in, energy out, basically all about diet and lifestyle. And as a result, we see a lot of initiatives talking about healthy lifestyles, physical inactivity, food systems, all sorts of things. But how close is that to the actual real definition of obesity and the biology behind obesity? Short answer, nowhere near. So WHO, World Health Organization, and most recently updated from the European Commission in 2021. So since 1948, WHO has defined obesity as abnormal and or excessive accumulation of body fat, adiposity, that presents a risk to health. See the left side of the screen, how obesity is interpreted in policies. See the right side of the screen. Not very close at all, is it? Now, what's even more important, particularly when we start talking about obesity in pregnancy and the first 1,000 days of life, is that in 2021, the European Commission actually categorized obesity as a chronic disease, which in turn acts as a gateway to a range of other non-communicable diseases, such as diabetes, cardiovascular diseases, and cancer. So by rights, we should be having all policy discussions based on this definition, flowing from that definition, and seeing how we can actually put in place systems, infrastructures, policy interventions that help health outcomes based on this. The right side of the screen, not the left. You may be seeing it on the other mirrored side. Now, you may say, well, why does that matter? Because actually, in my research world, I have a very narrow lens. It's based on a lot of previous evidence. So I'm doing more research needs to be done, and I'm implementing that. Now, again, from a policy perspective, having the right baseline scientifically accurate and precise baseline, it matters because in effect, that then allows obesity to be addressed in many shapes, shades, and sizes. We're not talking about waiting until we see weight in pregnant women. Your insulin resistance starts in the first trimester if they didn't have onset of obesity prior to pregnancy. The scientifically and medically accurate definition of obesity, most importantly, allows policymakers to have a system to actually address early diagnosis, early diagnosis, screening, treatment, and long-term management as part of an NCD, non-communicable diseases framework, like we already have for diabetes, cancer, cardiovascular. At the moment, obesity is outside of all of that. In effect, adversely affecting the ability to address obesity in that 224 million adults already living with obesity within the European Union. So now we try to hone in a bit on obesity and pregnancy. And I'm sure, because we discussed this in the virtual green room, colleagues will talk a little bit about, labelling matters. I'm going to leave that to my esteemed colleagues. Now, the element that I'm going to push on in here is that, it's not only about labelling, it's about getting a diagnosis. Because when you have a diagnosis of the biology related to the biology of obesity, again, from a policy to practice, regulatory, reimbursement, everything perspective, all of a sudden, women who are coming up to thinking about becoming pregnant, actually, they will get screened for various potential medical conditions that could affect the health of their offspring. Not the case currently, it's not automatic. Automatically, they'll get screened for insulin resistance, which is currently already used as a diagnosis tool for diabetes and others, but why not have it as a biomarker amongst other types of hormones, cheap and easy to screen for, to pick this up? Again, why does it matter? Because what happens during pregnancy will affect the health of that offspring into their 40s. And what that means is as well that there's an increase of risk or predisposition from 30 to a massive 80% for obesity in the child where the parents have obesity. So all of this is springing through from keep talking about weight in policy and keep expecting us to have exactly the same conversation of why are the obesity prevalence numbers going up generation after generation? It just doesn't make sense. Now, in fact, my more or less final point here is, again, why does all of this matter? Well, actually, I mentioned a bit earlier about obesity national plans within the non-communicable diseases framework. This is not an abstract concept. It is a policy and, in fact, legal concept because at global level, the WHO, so the World Health Organization, all regions across the world, at national level, everyone has an NCD plan or NCD framework plan for rare diseases, cardiovascular diseases, cancer, diabetes, COPD. All of those, obesity, I'll take out rare for the minute, but all of those, obesity acts as a gateway chronic disease. Why is it that there is such a reticence to actually give the same parameters to obesity onset, disease progression, so that we can actually address it and prevent 80% of type 2 diabetes, 35% of ischemic cardiovascular disease. The list goes on. And for those of you wondering about what are all those bubbles, that is actually the 236 medical complications of obesity in terms of hard evidence, red being hard evidence, the top level. So as you can see, actually making sure that we're addressing the chronic disease of obesity, the biology of obesity early on, and actually screening for it before we see the weight in people who are contemplating procreating, people who are in the first and early trimesters of pregnancy. That's when it is so important. And from a policy making perspective, that is one of the major missing links. And as researchers within this community, within the policy community, we rely on you to actually be brave and ask those questions and not just stick to the same old weight, nutrition. Well, that's my narrow element. We rely on you to put it in context and ask for research as well that can actually cover the biology of obesity, because, dare I say it, we're all women presenting on this call. This all affects us. It could have affected our mothers. It will definitely affect the next generation. So I'm sure my time is up. So I'm going to hand over now to our next speaker, who will talk more on the non-policy elements of all of this. Thank you.
Thank you very much, Jacqueline. Thank you for your introduction there. I'm going to move on to our next speaker. It was going to be Dr. Christie Burden, but unfortunately she can't make it today. So very kindly, her colleague Aisling Geraghty, the Clinical Trials Manager for the Bump2Baby Me project, is going to step in. So over to you, Aisling. Thank you.
Hey, thanks, Joe, and wishing Christie a speedy recovery as well. So I'm going to be presenting some first slides that she was going to be speaking about today, and this is kind of around weight management, nutrition in pregnancy, and obesity as well, and just some of the risks for everyone. So I suppose one of the main questions is why focus on weight management in pregnancy as well. And so I'm going to be discussing a bit further why you would look at those improvements in antenatal care and how this is an investment. It's not only for the woman, but also for future generations as well. And often it's very clearly seen in antenatal care that it's not just, one person, it's kind of two in one, but also investing in future as well. So pregnancy is increasingly recognised as crucial for addressing weight management, but maternal health as well. And it is an opportunity to reduce malnutrition, and that's both in terms of under and overnutrition as well. And this is really with the aim of reducing the risk of non-communicable diseases in the mother, and also the passage of risk to her offspring, as Jacqueline mentioned as well earlier. So when we think about obesity or nutrition in women, globally, there's been a rapid rise in obesity among women of reproductive age. So this is before pregnancy, and it's estimated that it's 21% of women of reproductive age in the world predicted to be living with obesity by 2025, so not that far away as well. In the US, I think it was in 2012 that it was almost 30% of women that were living with obesity who were aged between 20 and 39. And there's also been an increase in obesity in kind of low middle income countries as well, such as or in Brazil or South Africa. So it's 1 in 5 women in that sort of reproductive age bracket. And when we look at the UK, for example, in pregnancy, it's 27% of women that are living with obesity that are currently pregnant. And there are known risks for this as well. So there's been a lot of different systematic reviews that have looked at with obesity, there's an estimated from 3 to 10 times increased risk of developing preeclampsia in pregnancy, and also then known impacts both for the mother and for the offspring. So this sort of is across pregnancy as well. So in early pregnancy, there are risks with obesity for the offspring, in late pregnancy as well, for the mother's health in terms of preeclampsia or hypertension, also increased risk of gestational diabetes, but also growth for the baby as well, with macrosomia or being born large for gestational age. And then also post-pregnancy, there is still an increased risk for the mother, that is in terms of obesity, later in life, an increased risk of type 2 diabetes and cardiovascular disease. And then, as Jacqueline had said, the increased risk later for the offspring as well. So I suppose what can be done, which is the area that we're sort of very focused in, that everyone is interested. And it's bringing back to the idea again of this first 1,000 days. So this is sort of the span from a child's life from conception up until about 2 years of age, so 24 months roughly. So it's a time where the infant's brain, body, immune system all grows and develops significantly. So really this area of pre-pregnancy and also pregnancy, it offers I suppose that window of opportunity to establish services to improve health and prevent that intergenerational transmission of non-communicable diseases. So when we're looking at this time point as an area where we can support mothers, whether it is kind of with preconception where possible, and to provide support to the mother, then also while they're engaged with the healthcare system, with antenatal, postnatal care, providing support and for management, and then also later on, then we have an opportunity to help improve future health as well. And so that is the idea of the intergenerational cycle of non-communicable diseases, as Jacqueline mentioned. And there's a lot of information, a lot of data has shown that maternal obesity could predispose offspring to later life of also having obesity. And it is really this time that if there is a way to support and help at this time point, it's, I suppose it's in everyone's interest as well. So I'm just going to skip to, these ones here. There's a couple of different areas of interest for research around what can be done. This is with either medication or lifestyle interventions. And there has been extensive systematic reviews looking at certain factors like diet or physical activity in pregnancy and how that could impact just one aspect of, I suppose, obesity being with weight gain or weight management later. So there's been a lot of those areas looking at it, and they found that physical activity could help reduce gestational weight gain as one factor, and reduce risk of gestational diabetes, hypertension, cesarean section, and some of those outcomes as well, that it could help improve maternal outcomes then. And then I suppose when you're looking, so not just antenatal, but you're looking at postpartum, so some would say that it's the same but different. And there are a lot of different factors that while similar in antenatal care, it's also relevant for the postnatal period, but slightly different supports will be needed really for the mother and the offspring and family unit postpartum then. In terms of interventions in pregnancy or around that time point, there have been a lot of work around what research has been done at the moment, but there are still a lot of areas for improvement. So one of the areas when you're looking at research is, I suppose, the penetration in the population and participation of who it applies to and I suppose how it helps as well. We look at how interventions are delivered. So there's been research looking at who delivers interventions around supporting a mother with obesity in pregnancy or postpartum, whether it's healthcare professional delivered or not. And then we'd look at different lifestyle interventions and how, I suppose, what they delivered and what they're aimed or what they're targeting at. So looking at kind of behavior change techniques, targeting, I suppose, different, because we know that obesity is multifaceted. So looking at the different areas of targeting within interventions, and that also needs a couple of thought as well. And then we've also looked at, I suppose, the types of interventions, and there has been a lot of research around digital health interventions and them being acceptable in pregnancy and also to for women around that time point as well. So there are a lot of challenges around obesity with pregnancy and postpartum as well. I suppose even as Jacqueline is saying, in that preconception time point, if you could, I suppose it's a really key area to target. However, it's really difficult. It's estimated up to 50% of pregnancies can be unplanned. So really, if people aren't thinking about it, it's very hard to kind of target and give support at that time. As well, there's a lot of, I suppose, differences and inconsistencies around the actual screening and diagnosis or identifying obesity, as well as Jacqueline said, actually diagnosing that. And that can be quite a challenge then to start on treatment then. In terms of guidelines, there's inconsistencies across countries, across different hospitals around how this is treated, if it is, as well. So that is quite a big challenge too. And then, of course, as everyone will be aware, there are a lot of challenges around time availability, resources for healthcare professionals that will be working in obesity care. So a lot of challenges as well. But I suppose optimistically, there has been a bit of movement around the area. So Figo are the International Federation of Obstetrics and Gynecology. So they've released a lot of guidelines around kind of obesity with preconception, also during pregnancy and postpartum as well. And I suppose it's the Make Every Contact Count is the initiative around obesity and nutrition. So it's kind of encouraging every contact that a healthcare professional has with someone planning pregnancy or considering it beforehand, during pregnancy, and making that contact count and the conversation and providing support. That's the end of that. So I'll pass back over to Jo and then back to Charlene. So thanks very much.
Thank you, Aisling. Thanks for stepping in. So yes, next we have Charlene O'Reilly, our Bump2Baby and Me project coordinator. So I shall let her introduce herself a bit further. Over to you, Charlene.
Thanks a million. Oh no, stop! Don't stop presenting. Thanks a million. I would just like to introduce myself. Now let me just get this to go down to the next slide. And it's just not moving for me. Hang on a second. There we go. So just to introduce myself, I was just asked to put this in. I'm a registered dietitian and I'm based here at UCD, and for my background, or for my sins, as some would say, I'm the lead on the Bump2Baby and Me project. And so in terms of what Bump2Baby and Me is as a project, it's a 5-year EU Horizon 2020 project that's collaboratively funded through the NHMRC, which is the National Health and Medical Research Council over in Australia. So we have partners based in Australia, as well as Denmark, Spain, and you'll see on the next slide the breadth of our partners. So we have quite a lot of partners spread in, as you can see there, the UK. We have Bristol as our clinical site, Dublin as a clinical site, as well as clinical site all the way over in Melbourne. So we're spread quite widely across the globe in terms of where the sites are, as well as our partners. So in terms of the actual clinical sites for the study, we have 4 hospitals currently running the study, and we've recruited just over 800 women with 200 per site. And then within each site, we have about 8 health coaches running the intervention arm of the Bump2Baby and Me intervention, as you can see there, the different sites for each of the countries. So in terms of what does the intervention involve for Bump2Baby and Me, as you can see there, the health coaches for Bump2Baby and Me are involved in delivering the intervention. They're trained healthcare professionals, and so they're delivering a health coach intervention that's delivered in both Spanish, obviously in Spain, and through English for the 3 other sites. The intervention is designed to deliver a holistic health coaching intervention that does have weight management as a component of it, and also physical activity and nutrition and lifestyle support for both mum and baby. So, and it provides continuity of care that overlaps with both the pregnancy component and the postpartum component. So it runs right the way through pregnancy to birth and for the first 12 months of life. And the health coach will continue to engage with the mothers through the app and provide really personalised content for each mum and her baby to ensure she's receiving the right information at the right time. So in terms of the study, as I said, there's 4 clinical sites. What we're doing is we're trying to align to deliver more optimized care. So I know Jacqueline pointed out that in terms of that first trimester, it is basically a very broad system. And what we're trying to do is provide better screening of women so that we're catching women to provide better care to the women that need it at the right time. So we're screening mums through a tool that we know will identify women that are at higher risk. So it does pick up women that are at more risk of developing gestational diabetes. So those women that have that greater risk of insulin resistance. So it's a rough tool, yes, but it does identify them, and we've shown through both biochemical means in other studies to identify those women. So the tool is delivered through routine care. We can do it without having to do anything invasive, which is obviously key from a policy perspective. If the women score greater than 3, they're invited to take part in the study, and they're randomised and consented at that point. They're then allocated to either the intervention arm or usual care. In the intervention arm, as I described previously, they're allocated to the Bump2Baby and Me app, where they're given a personal health coach who will work with the mum to give them holistic health coaching over an 18-month duration from early pregnancy right the way through to 1 year postpartum. So at the moment, we've screened more than 3,500 mums, which is actually really good penetration of usual care, which is something that we're actually quite proud of, that we have actually gone through a lot of routine antenatal care. We've allocated and screened and invited and consented 857 mums, to which we have now those numbers, as you can see there on screen, in each of our arms. So at the moment, in terms of the study, as you can see there, that's the timeline for the study as it stands. We're currently obviously in 2022, and we have recruited our last participant, and we're on track to maintaining our course, which is actually unusual considering we started just as COVID kicked off. And for a lot of studies that got funded in our tract, they were all planning face-to-face recruitment, etc. So we're quite proud of the fact that we're still on track to complete on time and on schedule. So our study results are due out in early 2024. So in terms of, why is obesity relevant to Bump2Baby and me? So pregnancy, as we've said, and Aisling highlighted earlier, it is definitely a window of opportunity. And for most mothers, it's a chance where they're engaging with health services. And it's a chance for them to actually engage at a proactive level, to potentially see that they could improve their health in a proactive way. And it potentially, as Aisling was talking about, is a way of intergenerational transmission of NCDs to try and stop the transmission of NCD transmission. So as I was previously shown, one of the key things that we want to look at is looking at that prevention of transmission of NCDs. So how is that going to happen through Bump2Baby and me? Well, we're looking, as I said, at identifying women early. So using that screening tool in the first trimester, yes, we are using BMI. I acknowledge it has its many, many limitations. But as I said, the screening tool is a way of recognizing that there's a family of risk that's being identified through those other risk factors as a component of BMI being one of those things, and that women with obesity are likely to be more eligible also within that screening tool. Also within the app, we are also training our health coaches to work with women to set personalized goals around weight management, acknowledging that obviously the roots of obesity go deep and that they do need to set personalized goals that work with the mums around the facets of day-to-day life, and the fact that mums may not want to set goals around weight management, and they may have key goals that set around sleep, stress, and those things may actually be facets that are actually more higher priorities in the life of the mum, or pain, etc. And that might actually be something that is actually a higher priority for mothers and may actively be a better strategy for managing the life of that mother at that time. So the resources that we have put together have also been reviewed and managed in a way to help use person-centered language and to be put together in a way that tackles the mum as a whole person and looks to the health of her as a holistic person and that of her baby. We've also taken personalised health coaching, looking at obviously gestational weight gain as being a positive thing, appropriate postpartum weight management as opposed to it being a focus, it is a component. Dietary advice, looking at nutritional quality as opposed to constantly looking at weight management, physical activity as a positive thing and building that into infant physical activity, well-being and mental health support being one of our key tenets, breastfeeding and breastfeeding support, and also partner engagement as being one of the key things that we think is really crucial in the personalised health coaching, and also building in peer support as a component of the app and also the intervention overall. So I'd like to hand over now back to Joe and to Helle.
Thank you very much, Charlene. Yes, next we have Helle Turkelson-Meindal to do the next part before we move on to some questions. So over to you, Helle. Thank you.
Thanks a lot, and thank you for the introduction. My name is Helle Turkelson-Meindal, and I'm from Denmark, the University of Aarhus. And I'm a professor in health promotion and working primarily within sort of health promotion and prevention of diabetes, obesity, cardiovascular disease, and so on. I am part of a number of great studies working with health literacy, where obviously Bump2Baby is one of them, but also a couple in Denmark, the FACEIT study and the HELP study, which is about health literacy in pregnancy. And actually also I'm part of a father's health literacy study at Deakin University, Australia. So I find, as you can hear, health literacy as a very interesting subject within this field of obesity. So what is health literacy? That is, I just see, right. Health literacy is actually sort of very brief. Being health literate will say that you are able to have access, understand, appraise, and use health information and health services in order to make sound decisions about your health. So it includes the capacity to communicate and act upon health decisions. Health literacy is a combination of personal competences and situational resources, meaning that the resources around you and the health system have a lot of impact on your perceived health literacy. We work with health literacy in Bump2Baby. We also work with digital health literacy, which will then, that is sort of the ability to access electronic sources. I'll just see if I can switch to, hang on, right. I think I wanted to add this, yes. So low health literacy is known now to be an important risk factor for future ill health. And again, that is because we know that people with low health literacy levels or challenged health literacy levels, they won't respond as well to health education, and they tend not to use health services as much as those with a higher level of health literacy. So definitely improving a group's health literacy will lead to a more fair, and it promotes health across populations. And important, and I can't emphasize that enough, the responsibility for health literacy lies not just with people themselves, but to a large extent on society and health services. What we also know about health literacy, and especially according to obesity risk, is that we know that obesity is a very multifaceted chronic or long-term condition. There are several causes and predictors and determinants, and one of them is actually health literacy, we know by now. And how can we then work with health literacy in this field? One opportunity is to actually make access and navigation a lot easier, and that's what we've been seeking to do in the Bump2Baby and Me study. And another one is actually avoiding complex and stigmatizing language. And I'll talk more about that in general, but first I'll talk about the way we work in Bump2Baby and Me in general, because we know, for instance, from this UK publication, that language matters. And what we know especially about obesity is that we have so many, in the UK, you have so many members of the Obesity UK, and on a daily basis, they hear very bad language about their obesity. And that can be like they feel they are stereotyped as being lazy, uneducated, lacking willpower, binge eaters, lack self-discipline. That is just to name a few, but this is just the fact that people with obesity face this kind of language every day. So this is what we have. This is one of the reasons why this is, of course, addressed in the Bump2Baby and Me project. One way of doing it is, Charlene already introduced the app, which is quite a simple platform. quite easy accessible. It's designed to women with low education, low resources, and people from remote settings. At least they are also available. They are also able to participate, and also the health coaches are sort of trained to guide the participant through the sort of maternity healthcare system, so they can actually better navigate in maybe a complex health service. But that's part of the health coaching, that they actually support the women in wherever health service they may want to use. And also in general, the health coaches are trained to sort of address barriers that the women may experience in accessing healthcare during their pregnancy, and actually also after pregnancy. And then obviously, as Charlene also emphasized, the intervention offered is in general tailored to support very personalized needs. So that's what it's how we have sort of implemented health literacy into this project. And we also measure health literacy at baseline before the women are actually referred to the project. We measure we measure with the health literacy questionnaire, an Australian questionnaire. We measure health literacy in broad terms, and we also measure digital health literacy before the project, and actually also immediately after the women have been into that intervention of Bump2Baby and me. So this was very short about health literacy within the Bump2Baby and me, but I can't emphasize enough the importance of bringing language in as a crucial component of any project in order to, again, address people's different health literacy and health literacy needs. Language matter. We want to work with a stigma-free language in health promotion in general, and in particular within these kind of projects where we don't deal with patients, because these women and their partners, they are not sick. They are maybe in a vulnerable position or a risk of being sick, but where we approach them here, they are persons with maybe overweight, maybe obesity, maybe in risk of gestational diabetes, but it's people like you and me that doesn't want to be stigmatized, and language can be a very stigmatizing issue. So as my last sort of go for this, I'll just put a spot on a way of addressing language that has been developed to a large extent in an Australian group working with stigma, and that's also sort of the principles for or the approaches that we have applied to the Bump2Baby and me, working with the curiosity, accurate, respectfulness, and empathy, rather than blame, irreverence, authority, and stigma. So I think that's my last slide here, and I'm really happy to discuss what have been said and to take questions. But I think I will hand over now to Lindsay again. So here you go. Thank you.
Thank you, Helly. That's great. And thank you once again to every one of our speakers for sharing your knowledge and information this morning. I'd like to now open the floor to any questions for our speakers, or if anyone's got any comments or any further information to add to what's been discussed this morning. And I've seen Jacqueline's put her hand up straight away. Jacqueline?
I know, don't sound so worried. I was going to say this. No. Very briefly, I'd actually like to pick up on the points on language. So within EASO, and actually based on another project called IMI Sophia, in which I'm work package leader on shared value, we've actually been talking a lot about language, but not only in terms of weight bias and weight stigma, but actually about usage flowing from the acknowledged definition of obesity. And I think that when, again, we actually flow from there, weight bias and weight stigma becomes part of the puzzle, but it's not the full linguistic puzzle. A conversation I was having the other day was about what about those who, for instance, particularly when we're thinking about pregnancy, what about those who've had bariatric surgery and then want to become pregnant? Odds are their BMI will show them as so-called normal, and they'll be hiding in plain sight in terms of the weight bias and weight stigma protagonists, put it that way, or antagonists. And so as a result, what happens is that when we only talk about weight bias and weight stigma, it's actually discriminatory against those people who are actually under treatment or serious management at any given time. And that's why within the broader EASO taxonomy project, weight bias and weight stigma sounds long, but I have to keep saying it, needs to be seen in context, and the real, and I'm speaking here as someone who's had bariatric surgery as well, let's be clear, so I know there's a special kind of stigma attached, but what we want to be able to do within the EASO, so HCP researcher, health professionals community, is to actually make sure that the language which you use is precise, which is accurate, which is respectful, and actually a lot of that weight bias and weight stigma will be significantly diluted, if not disappear, because then people won't be able to hide anymore behind their ignorance, and ignorance being not knowing and being proud of not knowing, put it that way. So that's really why we're building on a lot of work which is going on around the world, and not least the work that we started within IMI Sophia, to make sure that anybody with obesity, regardless of size, actually has access to a system and isn't forced into always saying, well, you're not big enough, let's just get your weight down, which is actually what's happening right now. And for everybody else, it's, well, good luck, because you drop out of the system. And then the other question I had very briefly is, I saw at the beginning of the presentations that ethnic diversity was mentioned. I'd like to know how people of, should we say, non-Caucasian ethnicity and heritage were included as part of the, if you like, the approach, particularly for the app. Because I can tell you, I've been volunteered to find people of colour for various focus groups. And, so I went to my very middle class, I'm Guyanese originally, South America. So I went to my very middle class, Black and ethnic minority, family, friends, whoever else. Not one of them was willing to step up, because actually they didn't see themselves represented. And also culturally, how we view size, I won't go to the whole discussion, but how we view size is very different to, should we say, majority ethnicity across Europe. So I'm just wondering how this was integrated, because proportionally it's people of colour who are actually adversely impacted by untreated, uncontrolled obesity, type 2 diabetes. So that was actually my question. How will we integrate it?
Thank you, Jacqueline. I think Helly put her hand up just as you were talking about your first part, so maybe Helly could just come back, and then maybe Aisling or Charlene could respond to your question. So Helly, over to you first, please.
Thank you, and thank you for these really relevant comments. And to sort of comment on the first issue that you raised, I think in order to leave no one behind, we need to not only work with health literacy on an individual level, we need to work with health literacy responsive organizations, meaning that you need to build up your systems so you have enough knowledge about your users, and that very good way of getting this knowledge is, of course, to involve your users in every step you build up in your organization. And obviously you should also have the voice of the people having had surgery and so on. So I think one thing is actually to work on an organizational level, and in particular in that case also work with the knowledge of the health professionals and develop their sort of health literacy skills or health literacy responsive skills. So that is definitely one step to go towards that issue. And in order, I think, well, no, I'll give over the word to Charlene in order to talk about the ethnic issues or ethnic diversity issues in this project. Thank you.
Yeah, so I suppose we were very conscious when we were putting together the project around diversity and bringing diversity to the fore, because it is absolutely an issue that we knew that the majority of the populations that were coming into, particularly in some of the countries like probably not so much Ireland, but definitely in the UK and Australia, there was a predominance of diverse cultural backgrounds that were going to be coming into the project. So we were very aware of that. So we were very conscious in using over sampling, in essence, imagery and language, and the way that we put together our resources for the health coaching, etc., were focused ensuring that we had examples and language and the words of people from different backgrounds. So it was definitely came into the resourcing of the project. So we do have images and a diverse background of people of all shapes and sizes in the project. Yeah.
Fantastic. That's so encouraging. I'd like to shamelessly promote the app then. Because it's a first, and also to take those examples into ongoing projects that we're working on, because I can tell you it's a struggle. It's a real struggle. So chapeau for actually getting this element in.
I'm talking to myself again, sorry. Thank you, Jacqueline and Charlene. Does anybody else have anything to ask our presenters? If you want to put anything in the chat, please do so. There's a Lucy Goddard. Over to you, Lucy.
Hi, yes, thank you for the presentation. It's really interesting work. I just had a question on the kind of weight management side of the app, and what kind of to advise women about their appropriate gestational weight gain. Just wondering how you're managing that in terms of what advice you're giving, if it's based on their weight at booking, and if they're following any sort of weight gain ranges, or whether it's sort of just a conversation about how they feel their weight is going, what they do if the weight goes above maybe what it should be, and what the approach is sort of on that side of things.
Thanks, Lucy. Ashlyn, I'm going to pick on you. I think you might maybe be able to answer that, or Charlene, one of you. Is that okay?
Yeah, Charlene, like that. Yeah, so we have different resources for the health coaches. So all of the health coaches are trained healthcare professionals as well from their background. And then they undergo a training program to make sure that everyone is giving, I suppose, advice in line with what we have planned out as part of the project. So it is personalized support. So it depends on the mother if they just want general advice around kind of appropriate weight gain, or if they have any concerns or any major issues, they are directed back to the clinical team and the healthcare team. It's designed to be a support, rather than very specific questions about exact rates. But it is all, so evidence-based advice around the support, what they can do to support their weight gain. And if they do have specific questions, it does go back to a clinical team and to keep it within the healthcare as well. So, read that answers.
And just to back up on that, we don't set weight targets. We don't talk about kilograms. That's not the focus of the health coaching. It's about not focusing on scales per se. It's about talking about food quality and diet quality.
Thank you. That's really interesting.
Thank you all. Do we have any other questions from anybody? Oh, Jacqueline. Over to you.
Okay, it's a real question as well now. I was also thinking, because again, in the policy world, they love to scramble everything together and talk about comorbidities. So my question is, again, because certainly with adult obesity, there tend to be 6 buckets of biological root cause, a nice chunk of which is endocrine disruptors and or mental health, so depression or other medication that people are on, all of these things. So my question is, was this taken into account in the approach, which is an extremely good approach, might I add, particularly from what I'm hearing on the app, but was this taken into account for women who actually are presenting with, for instance, hypothyroidism, endometriosis, or PCOS, all of these sorts of things, because actually that's going to have a massive impact on how their pregnancies run, what kind of personalized nutrition plans, and I'm not talking food, junk food here, I'm talking bioavailability for nutrition, absorption, and all of these things. So whether, sorry, pre-existing other medical conditions part of the whole approach?
Aisling, Charlene?
Yeah. So we collect a range of different information. So their medical health records are collected on participants. Now, if there's a lot of complications at the start of pregnancy, there are certain exclusion criteria. So if it is quite complicated, they wouldn't necessarily take part in the trial. But if they develop it as they progress through the pregnancy, that is collected, and we take that into account more at the analysis stage. But at all times, I suppose the intervention is meant to be as a support, an additional support for the pregnant woman as well. So it's more giving advice that way. Health coaches, they can share, the participant, it's up to them really to share what they want with the health coach. So they can share if they have particular conditions. But it is any sort of treatment or any considerations that way does go back to the clinical team to make sure that so their treatment sits with them. But support will be tailored. So if there are certain considerations, they let the health coach know and they can tailor, I suppose, what sort of support or advice that they want to focus on.
Yeah.
And that's
Which
the
is
idea.
Brilliant.
Yeah.
Which is brilliant, because one of the big issues that we're seeing across Appland is that essentially there's no interoperability or even interconnectivity with the ongoing the ongoing electronic health record. And one of the biggest dossiers coming through is actually the European health data space. So using health information and health data, including apps like these, as part of the clinical co-decision making. So patients as partners with their clinical team, and actually being able to look outside of primary, secondary and tertiary care delivery sites. So things like this, we would want to say, how can you bring that data into, or health information into the overarching electronic health record, both for primary and secondary use of data down the road? So that's partly why I asked, because if it's in a silo, it's useless.
Yeah, I mean, one of the good examples I suppose we could use from Bump2Baby is gestational diabetes. So say, for example, a mum gets diagnosed, we find that out, we have an additional consult with the mum live, but we also feed that information back through the clinical team. And so the multidisciplinary team know that we've had a consult and we're sharing information with them, so that we're not operating in silos, as you said, Jacqueline.
Yeah, it's fantastic.
Thank you all. I think we've got time for another question. And Alice, you've got your hand up.
I'm also on mute. Hello, I'm Alice Bullis from Sheffield Hallam University. I just had a quick question about body measurement. At this, I assume at the start you are, because of the screening, you are taking BMI. I just wanted to know, is there any other body measures that you're taking of these women pre and post this intervention?
The way we're trying to do it is, I suppose, as least burden as possible, and a lot of it had to be done remotely. So it's mainly just height and weight that's being collected for at the start and then at the end. Now we have an in-person visit at the end where they'd be coming in to repeat them, and we've infant measurements as well. So that's from that side, we're collecting kind of self-reported infant measurements at birth, and then 3 months, 6 months, 9 months there. But we aren't collecting a lot of other body measurements for the mother throughout the study. No.
Okay, thanks.
Thank you. We are actually at time. I had lots of other questions I could have posed to the panel, but I say we're at time, or even 1 minute over. If you just bear with me a second. Need to go all the way to the bend. Okay. Hopefully you can all see my last slide now. So thank you ever so much to all of our speakers again, and for all of you for raising questions and attending this morning. We would very much like everyone to keep in touch with the Bump2Baby and Me project. So the first thing you can do is attend our next policy forum meeting, which is seems a long way off, but I'm sure it'll be here before we know it. So on the 24th of November is our next meeting. We haven't got a topic for discussion, so if anybody does have any ideas, please put them in the chat or let us know. If you would like to extend some discussions on obesity, let us know. You can also follow us on Twitter or LinkedIn, or you can subscribe on our website for updates. And please, I think Lindsay will put in the chat our feedback form. It's only a few questions. It's really useful to get some feedback of how you've found today's event. So thanks once again to everybody. We look forward to meeting everybody at the next Bump2Baby and Me forum meeting, and please enjoy the rest of your day at whatever time it is. Thank you very much.